Holm holds a degree in medicine and in philosophy and religious studies he's from University of Copenhagen. He also has a master's degree in healthcare ethics and law from the University of Manchester and a diploma in health economics from the Danish Hospital Institute. He holds a PhD and a higher doctorate from the University of Copenhagen, and has been president of the European Society for Philosophy and Medicine and Healthcare, and president of the International Association of Bioethics. He's also a former member of the Danish Council of Ethics and of the National Council on Bioethics. He was the editor of Journal Medicine or Medical Ethics from 2004 to 2011, and is since 2011 the editor of Journal Clinical Ethics. A lot of words, but I'll give the word to you, Søren.
Okay, thank you very much. I'm to some extent an outsider to this, as I'm not part of the project, and so the only thing I know about your project is sort of what you can glean from its websites and other information. And I've been asked to talk about the ethics of informed consent. And I think it's important as an initial observation just to note that informed consent is not valuable in itself. Informed consent is a tool, it's a procedure, might even call it a technology that we have developed and that we employ with the aim of protecting something that's valuable. And the things that we want to protect are ethical values, legal considerations, and informed consent is just the procedure by which we protect these. And of course it has a long history, and it's very important also to remember that initially when we developed informed consent, it was in the context of what we would broadly see as clinical research. It was in a context where a doctor who was also a researcher met a patient in the context of that patient being ill, but after having developed the procedure of informed consent, we then broadened it out to cover almost all kinds of biomedical and also increasingly now social science research. So what are these considerations? What are the ethical values that we want to protect? Well, first of all, various aspects of self-determination or autonomy, if you want to use that term, because our participants in research have to accept that they are part of our study. They have in some way to make it sort of part of their own life. They have to know if there are possible harms. Of course, a lot of research doesn't create any particular harms or risk of harms. But even the research that's harmful often creates some burdens, at least on the time of participants. They have to set aside time to be research participants. So they have to know that, and they have to accept it. And sometimes, of course, there are also considerations of bodily integrity that's involved, just as we want to protect people's self-determination. If we, in various ways, want to invade their body, then their bodily integrity is also involved. And then increasingly, as data has become important in research, we've come to realize that there's also a cluster of concerns around control over personal information, privacy, and confidentiality. It's also rather important to note that informed consent works together with another right that we also think that people who participate in research have, and that's the right to withdraw from research. Now, if we thought that the alternative to informed consent, for instance, in using data that we already have, would be to give people no information and therefore not try to extract any consent from them. It's important to note that if you don't know that you're a research participant, if you don't know that your data are being used, you cannot exercise the right you have in all the guidelines in the Council of Europe, Bioethics Convention, and so on, to withdraw from research. So informed consent and the right to withdraw play together in various ways. If we consider informed consent and direct research participation, the context, the situation where we want someone to come to our lab and we want to take some measurements or ask them questions or do something, collect data from them, then of course informed consent is possible for the initial data collection and the initial use. We can explain to people exactly what it is that we want to do and what we want to use the data for. However, in many circumstances, we want to collect data for future use where we don't know exactly what that future use is. We might not even know what technologies will be available in the future. For instance, if we collect people's tissue samples, we might not be able to say with any specificity how we can analyze those in the future. And one suggestion to how we should handle that is to say, well, people should give broad consent. We should just say to them, well, we don't know what these things are going to be used for, but we'll use them for health research, and we will keep your data confidential, and you don't have to worry about it. The problem with broad consent is that its sort of ethical validity, at least, is somewhat questionable unless it's combined with a robust withdrawal possibility. The further problem is that if you look at the legal regulation in different European countries, you'll find that the degree to which they allow broad consent varies quite considerably. Now, people have thought about it, and especially Jane Kay and her group in Oxford have thought quite a lot about it, and they have suggested that in large-scale projects, you should instead implement what they call dynamic consent. You should keep in touch with your research participants, and if and when you want to use their data for something which is completely new, you should inform them and ask them whether that is okay with them. So essentially, you should keep in a relation with your research participants where they have a possibility to say whether or not the new uses of their data is something that they are comfortable with. Now, dynamic consent, of course, requires significantly more investment than broad consent does, because broad consent is a one-off, whereas dynamic consent requires an ongoing relationship, staying in contact with research participants in a longitudinal project, but it does have the advantage of protecting the interests, both the ethical and the legal interest of participants to a considerably larger extent than broad consent does. The other informed consent issue that has become increasingly important is where we use data that has been collected essentially for clinical purposes in relation to a patient's contacts with the healthcare system for research. Now, again, we might think, well, we can solve this problem by getting people's informed consent to this kind of secondary use at the point of the clinical context. But that's not unproblematic. We know from studies of the informed consent process that in the clinical context, people are very much focused on their own health problem at that time. That's, of course, quite understandable. That's the reason that they are in contact with the healthcare system, and they do not really think about all of the other things that they give their consent to. It's sort of somewhat akin to the research that was done a couple of years ago, where you could get people to sign up to a public Wi-Fi node, where deep in the terms and conditions, they promised to give away their firstborn son to get access to the Wi-Fi node. That if we get research consent in the clinical context for sort of unspecified further uses, we have good reasons to believe that people haven't really thought about this. On the other hand, it may not be practicable to seek consent later. If you don't live in a very well-ordered country where you can easily contact people, it simply becomes very difficult to seek their consent later. Now, one suggestion, which I've been involved in developing together with a Danish colleague, Thomas Plough, is that we could, at a societal level, implement what we call meta-consent, where people in advance state what kind of research they are willing to let their clinical data be used for, what kind of researchers they're willing to give access to. Now, that could be implemented in Denmark or in Norway, because these countries are well ordered and know where their citizens and residents live and how to contact them. It probably couldn't be implemented here in the UK, and it can't be implemented at the level of an individual project. Finally, it's important to note that informed consent doesn't solve all problems, and interest related to privacy control of information requires more than informed consent. They require that within our projects we keep track of all the data flows so that we actually know where people's data are and what they're being used for. If anyone wants to read more about either dynamic consent or meta-consent, there are a couple of recent papers here on my last reference slide. Thank you.
Thank you, Søren. I actually want to give the word to Bernd Stahl. In all this switching around the roles, I totally forgot to present him. He's our ethics manager, Professor Bernd Stahl, and I hope you have some questions or can lead the rest of these presentations. I don't know if you also want to say a few words yourself, but at least thank you to you, Søren, and then I'll give the word to Bernd, who will be in charge of commenting. If I can find out here.
For this presentation, and maybe it's a good thing that I come after you rather than before you, because I think it's probably worth saying a few words about why we're doing this. So why are we having this webinar on informed consent? Why are we interested in this? And the reason for this is that in the HBP we are subject to ethics review, and the ethics management group is sort of the front line of interaction with the European Commission and their ethics reviewers on the various ethical issues. If you look at the Human Brain Project, you will realize that we have loads of potential ethical issues. So we have a large variety of things that people may be concerned about, and one of them has to do with clinical research, research on human subjects, and that's where informed consent comes in. We also do lots of other things. We do research on animals, we research lots of technical systems, and there are various questions about the consequences of the research, what's going to happen if this works out. We're going to develop an infrastructure. The idea is we're going to come up with new computing paradigms. What does that mean for artificial intelligence, and so on. Why am I saying this? Well, mostly to show you that there is a breadth of issues, and informed consent touches on numerous of those. Now, in the past, the European Commission, and in particular the ethics reviewers, have come back to us and asked us about a standard shared version of informed consent. Now, the problem we have here is the Human Brain Project has about 120-odd members, most of which are universities that do research in their own rights. According to European rules, we have to ensure, the Human Brain Project as a whole has to ensure that ethics approvals are present for the research, but by the nature of the European Union, that is done locally. So there is no central way of getting ethics approvals for the various activities. Instead, what happens is that the individual principal investigator, who typically is a task leader in the Human Brain Project, they are the ones who are responsible for the research. They are the ones who draw up the research protocol. They are the ones who get the ethics approval. They are the ones who then communicate the ethics approval to us, and we then collect those and communicate them to the European Commission. So we have a problem of consistency in that now you have people from all over Europe doing their research. And as you probably know, and Søren actually alluded to this, is that the individual European member states do things differently. And what they consider to be required in terms of informed consent, for example, doesn't necessarily agree. So what we're trying to do, and this is where Stephen comes in, and I think Stephen has joined us now, is we're trying to draw up a standard operating procedure which will develop what we would consider a sort of minimum standard of informed consent, which we can then propose to the entire project to adopt, so that researchers know what they will be required to do from the Human Brain Project as sort of a minimum expectation. That doesn't change anything about the principle that they will get the informed consent from their local or national authorized body, whatever that may be, whether it's a research ethics committee in the university or a national research ethics committee or whatever the actual body may be. So that's what we're doing, and that's why we have this webinar. So Stephen has drafted a first draft of this standard operating procedure, and he's going to present on this in a minute. And we've asked you, as the external presenters, to give us your insight into what you think are key issues at the moment, so that we can make sure that what we're doing is actually up to standard and works. And with that, I think I would, just in terms of the structure, I would suggest, Karen, you actually do you introduce the speakers and lead us through the proceedings. And I would just start off with a quick question to Søren, and I think what we should probably have is a brief question and answer session after each of the presentations, and then probably a joint discussion at the end. But my first question to Søren would be the difference between pure research data and research data collected in a clinical setting. So you referred to that towards the end of your presentation and said, no, it's unclear whether somebody who is in a hospital who has a particular health need, whether they can actually be considered to be consenting properly, because they're patients, they have other things to worry about. And I understand that. However, in the Human Brain Project, we have a number of studies which are conducted with healthy volunteers. So my question would be whether your reservations about broad informed consent would also apply to this sort of study where you're working with healthy volunteers as subjects rather than with patients.
Well, I think the two situations are different, and of course it's also important to note that when we talk about ethics, we probably in reality talk about two things. We talk about ethics as sort of an academic consideration of, or as ethics as moral philosophy, and we talk about research ethics as a particular set of regulations. And the particular set of regulations may both allow you to do things that sort of from a more theoretical point of view you would find questionable, or it may prevent you from doing things that, from a theoretical point of view, you would find quite all right. And of course, from the regulatory point of view, in most countries, there's no problem in getting broad consent in the clinical context because it's allowed either formally or informally. So, for instance, in the Norwegian law on health research, it is explicitly stated that you can have broad consent. I think that the situation is better when you have healthy research participants, so you have research participants who are not, at the time when you, who are not sort of recruited in the clinical context at the point where they're receiving treatment, because you can probably get them to better reflect on being a research participant. I'm on the Ethics and Governance Council of the UK Biobank, which has 503,000 participants, and they gave broad consent when they entered to help, essentially to health research in the public interest, and I think that's all right, but it's partly all right because it's easy if you're a participant to find out what UK Biobank is doing. It has a quite good website which tells you what your data and samples are currently being used for, what researchers are doing with them. So you have a chance sort of to follow sort of not your contribution individually, but where the project in general is going. And I think I don't find that particularly problematic.
Mm-hmm. Okay. Thank you. So you've already answered my second question to some degree, namely so you refer to various legal standards in different European countries, for example, with regards to broad consent. Are you aware of any recent publications on that? Is there actually research? Is there comparative research going on that would allow us as a cross-European project to get a handle on, or even have an authoritative view on what is permitted in which countries?
As far as I know, there hasn't really been any comparative research. The Commission itself has a coordination action for research ethics committees across Europe and publishes various reports from that. Otherwise, I don't think there has been any comparative research since a project in, I think, in the late 90s, early 2000s, coordinated by Professor Derek Bielefeld, who is now in Durham, and that it was called Privy Real, and looked particularly at data protection legislation, but also issues of consent in the European countries. Of course, the situation, the legal situation is slightly complicated, of course, because the data protection regulation, the new data protection regulation, will come into force, and it has implications. It will come into force in 2018, and I think in May, and it has implications for what kinds of consent you can have. So the legal situation is somewhat fluid, also because the new data protection regulation has quite significant implications for the secondary use of sort of normal health data, that's clinical health data. But there is a working party which at this very moment is trying to draft a report on exactly how those clauses in the regulation should be interpreted.
Okay. Thank you.